Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so pleased you could be with us today. My very first guest is the distinguished Dr. David Gardner, pathologist here in Monterey. Dr. Gardner, thanks very much for being here.
Thanks for having me.
Dr. Gardner, let's back up for a moment before we talk about breast cancer. I want to learn about pathology training. You are a board-certified pathologist, correct? Mm-hmm. So it seems like that the pathologist at certain times doesn't get a lot of attention. However, of course, from the television point of view, there have been a couple famous pathologists. Isn't that right?
Yeah.
Like, wasn't Quincy a pathologist?
Quincy was a pathologist. There were forensic pathologists on CSI and some of the other shows.
Right.
Yeah.
So it seems like in Hollywood they give the pathologist more attention than the real life pathologist gets here.
Yeah.
In real life.
They keep us hidden in the hospital. We don't see a lot of patients, but
right.
We do play a big role.
That's right.
Yeah.
So Dr. Gardner, tell us about the training for pathology. Now, of course, we know that everybody who goes to medical school finishes high school, and you finish college, and then what?
Yeah. So then 4 years of medical school. And then after that, I did 4-year residency program. I did mine in New Mexico. And then after that, you can do additional training in one of the subspecialties of pathology. I did mine in kind of the more broad area of pathology, which is surgical pathology. But you could do dermatopathology or neuropathology or other areas in pathology. And so I did a 1-year program at Stanford and then came down here.
Okay. So Dr. Gardner, of course, you finished high school and you finished college. You got your Bachelor of Science. Mm-hmm. You went to the full medical school training, 4 years. Yeah. And then you did your pathology residency. That was in New Mexico.
Right.
And then you did a surgical pathology fellowship here at Stanford.
That's right.
Well, great. And now you're in Monterey. Well, we're delighted to have you.
Yeah.
So, Dr. Gardner, before we go on, who do you think makes a good pathologist? Let's imagine that we have a science-interested high school student watching the program today, and they might wonder if they would make a good pathologist. Like, who goes into pathology, and who do you think makes a good pathologist?
Well, I think it's an exciting field. It's a field where there's a lot of new developments, a lot of basic science. So you have to have an understanding of the basic science. And although there's not a lot of patient contact, we don't talk with the patients a whole lot, we do talk with clinicians all day, and we write reports all day. So communication is really important in pathology, being able to communicate exactly what we're seeing under the microscope to the clinician. And without that, the patient doesn't get the right care. So, someone who I kind of see it as a mystery-solving process. You get a specimen, you look at it, you try to figure out what it is just by looking at it, and then you put it through for processing, and it comes out the next day on the slides, and then you look at it on the microscope and you can see, well, what was that case? We get maybe 25 cases a day. They come out the next morning and we figure out what they were. So every day is 25 new unsolved cases that you get to figure out, and it's really, really stimulating.
Well, excellent. And Dr. Gardner, I know you're very good at your job. You're a really excellent pathologist. And all doctors, of course, have some knowledge about disease processes, yeah. But it's really the pathologist. We consider the pathologist really the expert in disease process. Isn't that true?
Yeah, and any time there's a diagnosis of cancer or some specific lesion, that diagnosis always comes from a pathologist.
Okay.
You can't move forward without a microscopic examination and a pathologist making a diagnosis.
Okay, which is a perfect segue to the topic I'd like to discuss today, mm-hmm. which is breast cancer, pathology, histology, and staging. I recall, Dr. Gardner, it used to be that we'd take a specimen of a breast lump. We would do a breast biopsy. Mm-hmm. We would send it to the pathologist, and it would be yes or no. It's breast cancer or not.
Right.
And then, of course, sometimes the pathologist would tell us if the margins were clear, which means did we get around it all the way. Mm-hmm. But it seems like now you guys are so sophisticated at describing histologically what you see, and there are certain receptors you look for, and hormonal receptors, yeah. And HER, NEU. Mm-hmm. So what I'd like to do in the next few minutes is teach the public, let's teach our viewing audience, how the pathologist stages and grades breast cancer when you look at it under the microscope. So let's start at the beginning. It's no longer true that all you do is to say yes or no breast cancer.
Right. Yeah, so Yeah, our goal is to give the patients as much information as they need to make the decisions, the treatment decisions, and to know the prognosis. What can they expect? What behavior is this tumor going to have? And so we usually start by receiving a breast core biopsy. They take a small piece, and that is a diagnostic procedure. So they aren't trying to remove anything completely. They just get a biopsy and they send that to us. And on all of our core biopsies, we have a really regimented way of examining these cores. And we have a long report, and we fill out probably 20 or 30 different parameters that we look at for each core. And we actually review them among all the pathologists and take a lot of steps to make sure that everything is perfectly accurate, so that the surgeon and the radiation oncologist and the oncologist, they all know what to do next.
Okay, so Dr. Gardner, we may get a specimen where you say it's lobular carcinoma, it's intraductal carcinoma,
right,
it's in situ carcinoma. So maybe we could go through the first stage, or the first issue that you address is really
right,
where it's located and the type of breast cancer?
Yeah, and sometimes on a mammogram or on palpation there will be a lump, and they take a core of that lump and it'll be a benign tumor like a fibroadenoma, in which case there's no worries, you don't have to do anything more. But if it's not, then we look at these little breast ducts, which is where the tumors usually arise, and we see if it's contained within the duct, which would be DCIS or ductal carcinoma in situ, or if it actually invades through the wall of that duct into the surrounding tissue. And that's where it's an invasive cancer, an invasive carcinoma.
Okay, so let me interrupt you one moment. When you say in situ, that we can have an in situ skin cancer, we can have an in situ colon cancer, breast cancer. What that means is it's very superficial, correct?
Right.
It hasn't crossed through the basement membrane. Can we say that accurately?
That's right, yeah.
Oh, so for breast cancer, the first thing you want to do is sort of describe where it's located and how deep it is?
Yeah, how invasive it is. And if it invades, that's when it can get into the bloodstream or into lymphatics. And a cancer localized to one place is not going to hurt you, but one that spreads to the other parts of the body, that's when you get the damage, and that's when you get problems. And so we try to predict what the lesion that we are seeing, that little teeny lesion, will spread to the rest of the body.
Okay, so what's the difference between, say, a lobular breast cancer and an intraductal breast cancer? What's the difference?
Yeah, so intraductal means that it's contained within the duct, and then there's an invasive ductal carcinoma and an invasive lobular carcinoma. And they have kind of different characteristics. They were thought to arise from different parts of the duct itself, one from the more terminal part of the duct, the lobule, and one from the duct. But it turns out that that's not entirely true. But when they invade, a lobular cancer tends to not create a lot of the fibrosis that you get with the ductal cancer. So it will go out through fat in just this little teeny lines of cells, these teeny little cells. And so what they're seeing on the image, they may see a little bit of a lesion on the image, but it may not represent the whole lesion. So for a lobular cancer, it's probably more widespread than they're expecting. And they go to lymph nodes very easily, and when they're in the lymph nodes, they're sometimes very difficult to detect. So when we look at the lymph node, then we need to use some special studies like a pan-keratin stain to sometimes pick up those cells.
Okay, so isn't it true that if you diagnose a lobular carcinoma, it's more likely, or the incidence of bilateral breast cancer is higher? Isn't that true?
Yeah, that is true, especially with an in situ lobular process like atypical lobular hyperplasia, and that can be true, yeah.
So it's more than just academic knowledge or an academic diagnosis. We're really providing more information to the patient and the oncologist, the cancer doctors, about what this patient may need to be cured.
Right, yeah, it behaves. Breast cancer is a spectrum of diseases that have different behaviors, and invasive lobular carcinoma behaves differently than invasive ductal carcinoma. So when we tell the the surgeon and the oncologist that this is an invasive lobular carcinoma. In their mind comes into, is an image of what this is, how this is going to behave. And it's very different for both of those types of tumors. Okay,
so in your very extensive report, you diagnose, or you tell the doctor and the patient the type of breast cancer, lobular or intraductal, et cetera. You can talk about how aggressive the cells appear, and you comment on the lymph nodes, whether they're invaded or not invaded, correct?
Right, yeah, so we grade the tumor.
Okay, so teach the public and teach me what we mean by grading the tumor.
Yeah, so the grade of the tumor is how aggressive it appears on the microscope. So we look at how rapidly it's proliferating, how rapidly it's multiplying, and the more rapid that happens, the more aggressive it is. So we look at something called mitotic index, or the mitotic count, which is the number of cells that are dividing. We also look at how often, is it making tubules? Is it recreating what it was kind of made to do in the first place, or is it just completely off the path and making solid sheets? And those two things kind of help us determine how aggressive. The more solid sheets it makes, the more aggressive it is.
Okay, so
and then we actually look at the actual cells themselves and see how unusual they appear compared to a normal ductal cell. If they're very bizarre, the nucleus has folds and the cells look very aggressive, then that's another thing. And we kind of take all of those things into account and give it a score, which is the grade. Like a Nottingham grade 3 cancer is the most aggressive. Nottingham grade 1 is the least aggressive. So a grade 3 is more likely to have a metastasis or spread to a lymph node or elsewhere compared to a grade 1.
Okay, so you do try to introduce some sort of a numeric objectivity to the grading when you diagnose and describe a breast cancer.
Absolutely.
Okay, so Dr. Gardner, what about the hormonal receptor status?
Right.
Can't you say is estrogen positive, estrogen negative receptors, and can you comment on progesterone as well, or is it just only estrogen? Yeah,
so we do look at estrogen and progesterone receptors. So it was noted that some breast cancers responded well to hormonal treatments.
Let me interrupt one moment so our audience understands. Things like tamoxifen, right, estrogen blockers, certain tumors seem to respond to that type of therapy, correct?
Right.
Okay, so you can assist the oncologist by determining if it's estrogen receptor positive or negative.
Yeah. And we do a special stain that just, it's a little kind of a marker that sticks onto the protein, the receptor, and then it lights up brown. And so if we see that brown stain, then that means that the protein is overexpressed, and that means that it's most likely going to respond to hormonal treatment. We look at ER, PR, and then the other thing that we look at that's newer is a protein called HER2/neu. And so there's a new drug that will actually, well, it's not really new, but it's newer, that will actually target the cells that overexpress this protein. Cells where the gene itself is amplified in the nucleus, and then that amplification causes increased production of the protein, and it lines the membrane, and we can look at that and say, well, there is a lot of HER2 expression in this case, which means that they may be a candidate for that kind of treatment. They're usually more aggressive tumors that express the HER2, but the good news is that there's a special treatment that will target that specific protein itself. It's one of the first targeted therapies in cancer, which is becoming a real common theme in cancer.
Dr. Gardner, that's really amazing and incredibly sophisticated that you can, with your special stains and markers and by looking under the microscope, you can provide huge amounts of valuable information to the patient and the cancer doctor. Yeah. It's really incredible. Yeah, so let's back up one moment. So we know if a tumor is estrogen receptor positive, tamoxifen may help. But what about the progesterone receptor being positive or negative? Yeah,
so sometimes there's a defect in the estrogen receptor, but the progesterone receptor is expressed. And that may still be a reason to treat. And sometimes people look at the differential between estrogen and progesterone, and that can affect the prognosis of the disease, in theory. But generally, the ER, or estrogen receptor, is the more important of the stains.
Okay. Now, there's an entire, it seems like a new area in this era of oncotyping, where you're actually starting to look at the actual genetic material in a cancer, right? Because as you said earlier in the program, there's a spectrum, many different types of breast cancer. It's not all one type of breast cancer. So what do we mean by oncotyping? Yeah,
so there are newer methods of looking at the genes, at expression. Oncotype specifically looks at 16 different proteins that are expressed in a different way than we can look at them with our special stains on the glass slide. So we actually take some of the tissue and send it to a company actually up in the Bay Area, and they evaluate it for expression of these genes, or, well, expression of proteins that are overexpressed with specific gene patterns. And it's another way of trying to predict behavior of the cancer. And sometimes it predicts behavior better than just the usual parameters that we look at, and sometimes it doesn't. So that's not needed for probably 95% of the breast cancers. We have enough information where we don't really need that additional information. But there are 5 or 10% where we do need to send that information, or send that for additional studies that will help us decide whether chemotherapy is needed or whether it's not needed, because it's a small tumor and we don't know for sure which way to go. So it can give us some added information.
Well, Dr. Gardner, I think you guys are incredible, and it's amazing to me, really, the amount of information that you can provide to not only the patient but the oncologist, the cancer doctor, to assist in the cancer treatment protocol. I think it's incredible. We have about 30 more seconds to go. Just to wrap up, can we teach the audience what we mean by a frozen section as opposed to a permanent section? I know sometimes in the operating room, before we do breast reconstruction, the audience knows I'm a plastic surgeon. Before we do breast reconstruction, we'll assist the cancer surgeon in removing the cancer, and we'll oftentimes ask for a touch prep or frozen section. Can we explain what that is?
Sure, yeah. So usually our specimens we process overnight and get the slides back the next day. With the frozen section or a touch preparation, we evaluate those while you're in the OR, while the surgeon is waiting for us, patients under anesthesia, and we actually freeze a piece of tissue, take the little shavings ourselves, put them on a glass slide, stain it, and look at it on the microscope all within about 5 minutes. And we can tell you whether there's cancer at that margin or not, or if it's a lymph node, we can say, well, there's tumor in the lymph node, or there's no tumor. And if there's tumor, then they might need to take out more of the lymph nodes.
Sounds like the pressure's on during a frozen section.
Yeah, it can be pressure, but it's enjoyable.
Oh, Dr. Gardner, we're really lucky to have you in the community. I know you're an excellent pathologist. David Gardner, board-certified pathologist. You're an expert in different areas of pathology, including breast cancer. Thanks so very much for coming on the program.
Thanks for having me.
Really delighted to have you here. Hope you come on again.
Okay, appreciate it.
And once again, this is Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and we will be right back after a brief pause for a very good cause.